Again, good morning, everyone, and welcome to the President's Quarterly Q&A, a chance for you, the UMB community, to ask the President directly any questions that may be on your mind. In anticipation that many of your questions may involve COVID-19, vaccinations, employee and student health, and the like, we've invited a team of experts here to help give you the very best answers. I'm sure everyone is very familiar with them by now. All three are with the School of Medicine. Dr. Wilbur Chen is an infectious disease expert and a member of Governor Hogan's coronavirus response team. He's also the chief of adult clinical studies section within the Center for Vaccine Development and Global Health. Dr. Marianne Cloran is a member of the university's recovery task force and leads the team responsible for the Safe on Campus program and the UMB COVID-19 hotline. And Dr. Mario Majette is UMB's medical director of student and employee health. I want to remind everyone that this is a Q&A program, so we do need your questions. Please find the chat button, select chat with host, write your question there, and be ready to ask your question when you hear your name. And don't forget, this program is being recorded and will be posted on the UMB homepage, umaryland.edu. Now let me introduce our president, Dr. Bruce Gerald.
Good morning, everyone, and thank you for being with us here this morning. I suppose, like me, all of you woke up to seeing a little bit of snow on the ground and a really slippery road, so I hope everybody has managed to suffer through that effectively and are back engaged with things. Today is December the 17th, which is remarkable to me. It's exactly almost 9 months ago when we went into this major change in terms of how we're dealing with COVID. So it's a milestone of sorts from that way in any event. One of the things that we've got coming up is the Christmas, New Year's holiday. And I hope that all of you, whether you're delivering direct care to COVID patients or whether you're teleworking or whatever, that you'll be able to find a time to take away from work and recharge and rest up and think about things other than COVID and work. And I think you all saw that the governor yesterday declared December the 24th a state holiday. So we'll have, I think you got administrative instructions on that yesterday, so we'll all get a day there to be introspective as well. Looking back over this year, it's been some year. It's really been unbelievable, all of the many things that we've done. And as I've looked at every school has had a significant impact on COVID, and every school has been able to maintain its educational and research programs, and for some of you, including delivering clinical care. We've got a tremendous amount to be proud of at this university. I'm certainly proud of it, and I know a lot of people around the state are not only proud of us, but have tapped into our experts and resources in a regular way. And I just was reviewing Dr. Kathy Newsel, who's a national consultant with the CDC, the WHO, the White House, with Operation Warp Speed. Dr. Chen is similar, and quite a few other people in the CVD, and we'll get to some of that when we get a chance. But it's not just a CVD deal. Many people have been involved with this, and so I want to thank the CVD, but I also want everyone else to know how important a role you've been playing. We now are seeing the first vaccines being given. You watch the news probably the same as I do and are keeping up to date on that, but we do have experts here who can tell us more about that today. So I'm hoping that at least some of your questions will be related to that. I don't mind telling you that I was in the Moderna trial. I volunteered because I thought it was important to say that I have confidence in the system that we have of clinical research. I've been in clinical trials before, and I will do it again. And I think it's a really important role for all of us. It's a responsibility to me to play. So that went very well for me. My arm was sore for a day or two, and I did fine otherwise. So I've been very pleased with the whole process and encourage you to carefully consider whether the vaccine's right for you or not. I know it was right for me. The other wonderful thing that's happened over the past year is the way that we have managed the University of Maryland, Baltimore in concert with the University of Maryland Medical Center. I'm very pleased about how we've coordinated care, resources, services around our entire two entities. We're planning to do the same thing when it comes to vaccination. We very much are moving toward having the campus center a site for vaccination. I hope to have that open soon. We don't know exactly when we'll have vaccines available for a broader population, but I'm hopeful that that will be sooner rather than later. And that'll include everybody in our campus that'll be available to them. So enough of my talking. I've asked Dr. Chen, Dr. Cloran, and Dr. Majette if they would give some brief updates, and then we'll start fielding any questions that you might have about COVID or about other things. So with that, let me start with Dr. Chen. Good morning, Wilbur. It's a pleasure to have you here.
Good morning, President Gerald. It's good to see you again. So, this week is pretty remarkable. It follows last week where we had, the approval, EUA approval of the Pfizer vaccine, and then the ACIP meeting its recommendations and solidifying those. We had the launching of the vaccines in limited amounts, but we have had a few hitches. So I thought I would just kind of mention them because it is part of our continued collection of safety information that we try to ensure the general population that we continue to review the safety and efficacy of these vaccines even after licensure. So the two things I'll mention is one, that there were some evidence of anaphylaxis, some severe allergic reactions after vaccination. Again, a very rare event that can happen after vaccination or after receiving any new drug. Okay, so that's completely unexpected. So it is a situation where we continue to monitor. It is thankfully a treatable condition. We recognize it early on and we can treat it. So we don't know, what component it might be of the vaccine, because that would certainly help us to be able to predict the people who might have that kind of a severe allergic response. And we also have had some evidence of Bell's palsy that have been detected in the studies. Now, Bell's palsy occurs at a frequency in the general population anyways. And so what we're looking at right now are a handful of cases, 4 in the Pfizer study, 3 in the Moderna study. And really, when you look at it, it's actually not at a rate that's higher than the general population, what you would see, evolve in the general population. Again, it's something that we watch very closely to monitor. But this is basically just to say that we have, these vaccines that are highly efficacious and available. We will continue to monitor the safety. This week, in fact, today, FDA is reviewing the Moderna vaccine. And I have seen the data, and I think that I can be as bold as to say that I think that we will have EUA approval of the Moderna vaccine. So that will be 2 vaccines by this weekend. And so the ACIP will be meeting on Saturday and Sunday to develop the final recommendations for the Moderna vaccine. But again, as we embark into next week, I think that we'll have 2 vaccines that will be deployable. So again, I think that is a sign of hope as we enter into the holiday season.
Dr. Chen, will you be getting the vaccine, you think?
I will wholeheartedly get the vaccine when it's made available to me, but I'll also admit that I'm in a position where I can telework most of the time, and I am not a frontline worker seeing patients on a daily basis. So I will gladly give up my position for those of my brethren that are, on the front lines and working hard, not only physicians or nurses, but respiratory therapists, environmental services that are doing their work right around the patients, everyone else. I think that they can go in line before me because I think that they're at higher risk and they're more important for the care of our patients than I am. But yes, when it comes to me, I will gladly accept it.
Great. Thank you for those comments. Dr. Cloran, I think I've got you next on my list. Good morning.
Good morning. Thank you for inviting me. So I'm the doc that manages the COVID-19 hotline services which are provided. We've been offering those since March, and they involve a team of nurses that work just with us really on the COVID response, and they've gotten to know us, really well. Calls to the hotline have, November hit a high point for calls to the hotline related to exposures and people in our community reporting positive COVID tests. And also the Safe on Campus program, which hopefully everybody on this call is registered for. And if you're coming to campus periodically, that you're completing your daily symptom monitoring reports. I wanted, at some point, and this may not be the point, but at some point I wanted to explain a little bit about contact tracing, because we've gotten a lot of questions from people about why certain questions are needed. And so if now is an okay time, I could share that.
Yeah, please do.
So if somebody is positive for COVID-19, the city, for here it's the city, it's the local health department is responsible for doing something called contact tracing, which has a couple of goals. One is to try to figure out how they got it, but the other is to try to figure out if they could have passed it to anybody else before the disease was recognized. And so even though the city still has jurisdiction over contact tracing, we also want to make sure that we know if there's any campus kind of risk. And so rather than wait for the city's decision and hope that they recognize kind of campus contact potential, we have our own campus-facing contact tracing process. And it starts with knowing that somebody has a positive COVID-19 test. And then we go through sort of a series of triage and questions to think about, well, if the person is purely teleworking and hasn't been on campus at all, then normally we leave the next set of questions, to the local health department. There's not a campus risk. But if it's somebody that has been involved in experiential learning activities around the time that they became sick, around the time of their test, or comes to work, or works at the hospital, works in FPI practices, whatever, then we ask a lot of questions to try to see whether or not that positive person was close enough to other people in our community and under circumstances, for example, sharing a meal in a break room. That's one where we see over and over again, people are very cautious about wearing their face masks and keeping distant, but they kind of forget sometimes and take breaks with each other. And when you're sitting with each other, sharing a meal, you're not wearing a mask. And if one of the people is positive, that's a high risk exposure. So we ask about situations like that where somebody else may be at risk so that we can notify people at risk. And if indicated, recommend quarantine. There's one other circumstance that is not, so I think everything up to now is pretty straightforward. Sometimes we go back in time pretty far to try to figure out how somebody got COVID-19. So if we don't find that, the circumstances where somebody in your household has it, okay, then it's pretty straightforward how you got it. And we don't necessarily have to go back, 14 days, looking for how you potentially got it. But if it's a mystery to us how you got it, then we may ask more intensive kind of history questions. And one of the things we're looking for when we ask those questions is any kind of a group event where you were in contact with other members of the UMB community where you may have gotten it and others may also have gotten it. So we want to try to make sure we identify any kind of group exposure history where we need to identify people that were also in that group and that may be at risk so that we can notify them. So if you are somebody that has been diagnosed with COVID-19, you may get totally different questions than your colleague who was diagnosed with COVID-19. And I think some people think that there's inconsistencies, but it's actually a fairly structured way of approaching it. And the next questions kind of depend on the answers to the previous questions. So I hope that made things more clear rather than muddy. But I just wanted to explain why it seems like we may be asking different things of different people.
Great, thank you for that. And third here is Dr. Majette. Dr. Majette, good morning.
Sorry, Dr. Joe. Good morning. Good morning. And everyone, good morning. So my name is Mario Majette, and I am a family physician and a preventive medicine physician out of the Department of Family Medicine and the head of our student health and employee health over here at the university. I just want to give two quick little plugs for some of the stuff that my staff has been doing and we will continue to do going forward. The first thing is that even from the very beginning, our staff has been on the front line, staying open, seeing people with COVID or COVID symptoms and testing everyone as much as possible. And so this is a little bit of shout out to my staff for doing such a good job and being dedicated to their jobs and their positions to make sure we keep our campus healthy. Second point is just another piece of that. We are going to be open for all the students that are listening and the staff that's on campus. Student health will be open through the holidays. So if you do need services, if you're feeling sick or if you have symptoms, please contact us. We have in-person appointments for those who need to come in to be seen and tested. We have telehealth appointments, and we have an increase in telehealth appointments, which we've made available for those of you who have a symptom or have a condition that may be more amenable to being seen by telehealth. So I want to put that out there. Two things that we're really pushing on right now is we're working really hard along with the hospital to set up testing for COVID. I should say to continue testing for COVID. Right now, we've been in the Ronald McDonald House, the former Ronald McDonald House here on campus. As of Tuesday, we moved to the campus center, the SMC campus center for testing. We are going to continue testing from that site, but that's also going to be the site in the future for the vaccine. The hospital is starting their vaccine campaign in the hospital, in the auditorium, but they plan to move to the campus center sometime in January. So we are working together along with them to make sure that not just the folks in the hospital, but everyone across the campus and everyone that has face-to-face contact with patients has an opportunity to get the vaccine as soon as it's available. So I'm going to stop right there and go into any questions that folks might have.
So I want to remind the audience that this is a question and answer, which means we need you to ask questions in order to provide answers. The questions can be related to COVID. A number of the vice presidents are also available on the call if it relates to HR or facilities or things like that. So please get your questions coming. Alex, have we had any yet?
Oh yeah, we have some questions. I guess let's start off with Jana Barcelo, who has a question I think a lot of people are wondering about. Is everybody cleared to get this vaccine? In other words, has it been tested enough? But Jana, go ahead and ask your particular situation.
Hi, thank you. So my husband is a type 1 diabetic, and to the best of my knowledge, the COVID vaccines haven't been tested yet in type 1 diabetics or those with autoimmune disease. Do you anticipate any effects from this mRNA vaccine having negative effects on those with pre-existing autoimmune diseases? And what's your advice on this population receiving the vaccine?
Dr. Chen?
Yep, this is a great question. So to dispel that, the studies that were performed actually did include high-risk individuals that had diabetes, hypertension, prior heart attacks, those sorts of things. So again, because we recognize that those are conditions that present high risk for severe infection. So in other words, yes, such people are eligible. Absolutely are the people that we want to vaccinate initially because of the high risk situation.
And Dr. Chen, you had a pretty good cross section of minority as well in the Moderna trial. Could you tell people just a little bit about that one too?
Yeah, we worked very hard with our local community members and leaders to be able to try to enroll what we really felt was reflective of our local Baltimore community, where our university resides. And so we did have a large proportion of our study population that was among the Black population in Baltimore. And we also had a sister site in Prince George's County at Casa de Maryland, in which we were primarily enrolling from the Latinx population that has been very severely hit as well in Prince George's. So again, we're trying to make sure that even our study population reflects the populations that have been hardest hit by COVID. So I think that that again is showing you the diversity in our study populations as well.
Alex, thank you.
Dr. Gerald, I'm sorry. May I add something to that?
Please.
It wasn't part of the question that was asked, but I just think it's important for folks to know. The few groups that weren't part of the studies were pregnant women, women that were lactating or nurse breastfeeding, and young children. So we just don't have good data on those groups of folks, but pretty much everyone else can and probably should get the vaccine.
Great comment. Thank you. Alex?
Questions are pouring in. Susan McKechnie's here, and she had a similar experience to you, I think, Dr. Gerald. Susan, go ahead.
Good morning, all. And as I'm not a medical professional here, as more of a curiosity question, at what point would a person in a clinical trial be told whether they received a real vaccine or a placebo? Because I would assume that the people who received a placebo would need to know so that they can get the real vaccine.
Dr. Chen, do you want to talk about that?
Absolutely. Boy, that's such a great question, because just yesterday, the study letter went out to the Moderna study participants, of which Dr. Gerald is messing up that he is one, and was just told that the unblinding process will begin in the next few, I think, weeks, and that you will be eligible if you find out that you got placebo to get the Moderna vaccine at Moderna's expense in the next couple of weeks. So I think that this process is unfolding right now, but the full intent is that yes, placebo recipients that were in our studies are going to be able to.
Susan, the one caveat on that is that it has to get the FDA approval first. Okay, the whole thing is on hold until FDA approves it. Then we'll hear from Moderna.
All right, let me give you an anonymous question. This woman writes, will there be any more guidance for human subjects research? We have not gotten any guidance during the second wave of the pandemic. As numbers are changing, will there be any communication regarding human subjects research, which is currently allowing non-therapeutic research?
We haven't made a decision yet about how broadly to allow human subjects research to roll out. It's been limited, as you point out, and we were sort of waiting to see the effect of this second wave. There is obviously more PPE. We do have a desire to get clinical research back to its full scale pre-COVID, but we have been cautious because, of course, you put the human subject at risk in this situation as well. So I'm sorry I can't give you a definitive answer except to say we have been paying close attention to that.
All right, Nicole Brandt is hopefully joining us. She's doing clinical work this morning, so she's trying to multitask. Nikki, are you there? I want to try again to unmute her. Nikki, are you there?
Can you hear me?
Great, go ahead.
Yeah, thank you so much. And thank you all for your expertise and leadership during this time. As noted, I'm a practicing pharmacist caring for older adults in the community. And those of you may be aware, our university is part of an age-friendly university system. And we just actually, UMMC became part of the age-friendly health system action community. And in light of that alignment and in light of the need within our community and beyond, was wondering if we're doing any age-friendly immunization events that are coming up to be planned, because I know that access, sometimes in terms of transportation or even just on our campus, may be challenging. So just thinking about our efforts as we reach out to our community of older adults. Thank you.
Unless one of the panelists wants to answer that. No?
Well, I can say that, you know, in our planning at the CDC ACIP, that we very much agree with that notion that we want to protect older adults. And in fact, you know, we're going to be voting on these measures this coming Saturday and Sunday in the ACIP public discussions. But I'm just broadcasting to you that, you know, part of the prioritization scheme is that we are going to be prioritizing older adults. And certainly, you know, 75 and older are a part of the population that we have definitive data that shows that the predominance of deaths due to COVID are among this population. So again, the notion of age being an important part of our prioritization for the care, but also for vaccination as well, is completely, I agree with you completely, Nikki. That is something that we on a national level also agree with as well.
And so what I would add is that the School of Pharmacy and Nursing and other schools have definitely made their workforce available to administer vaccinations when they become available to us. We certainly believe that the Community Engagement Center that we have in West Baltimore should be equipped to deal with giving the vaccinations as a site. But the bottom line is we are at the guidance of the state in terms of when, where, who, what, of how we do it. So we are enthusiastic about wanting our people and resources to be involved, but we have to stay within the guidelines of the way the state is asking us to do this.
All right, Dr. Cloran, one of your co-conspirators on the hotline, Charles Shelley, is with us. He has a question about the hotline. Go ahead, Charles.
Hi, Dr. Cloran, could you explain the two-step process when calling the COVID-19 hotline? Do I receive medical advice during that first call?
That's a good question. Thank you, Charles. And actually, before I answer it, I want to point out for those who are clinical people on this call, you may sometimes hear hotline used to describe both the UMMC employee health testing hotline and the UMB COVID-19 hotline. So I think it's good to make sure you know which hotline is recommended and the intent of the hotline. The hotline for the hotline that UMMC stood up is to coordinate testing for symptomatic and exposed UMMC employees, and they also extend that to some UMB clinical staff. So that aside, the UMB hotline that you're asking about, Charles, is 24/7, 365. So anytime you can call about a COVID-19, exposure, illness that may be COVID-19, COVID-19 positive test, and it will be answered by an operator 24/7. There's not a clinical person standing by 24/7. That operator will take your basic information, your demographic information, callback information, and the reason for your call using a template. And then a nurse will call you back and provide the nuanced advice, based on our protocols. We'll help you figure out what to do about testing, what needs to be done about isolation and quarantine. So if you call during normal business hours, you'll usually get a call back within a couple hours. Kind of depends on volume. It might be a little bit longer than that. If you call at night, you're not going to get a call back until the next morning. If you call on the weekend, the hotline is staffed on the weekend, and so you'll typically get a call back the same day if you call on the weekend, unless it's very late in the day that you make the call. But I think it's important to understand that the operators that answer the call are not equipped to provide, the answers that you may be seeking. They won't be able to tell you, whether to quarantine, where to get a test, things like that. But the nurse that calls you back will.
Thank you. Alex?
All right, let's hear from Mary Johnson. Mary, are you there? Mary? Well, Mary's question was, we talk about 95%
I'm here.
efficacy. Oh, go ahead, Mary, you ask it your way.
Well, I just like to know what 95% efficacy means. Does it mean that if you get inoculated, you're almost 100% immune? Or does it mean that 95% of people, if inoculated, are 100% immune?
Yeah, that's a good question. So I think, to dispel that, think of it as it's a 1 in 20 chance that you did not respond to the vaccination and get full protection. So in the clinical studies, when we did it in blinded circumstances, there were 8 people who were vaccinated who had COVID illness, and I think it was 162. This is the Pfizer data that received placebo and ended up being cases. So again, if you get vaccinated as an individual, you have a 95% chance of getting that protection. It's not 100%, but 95% is pretty darn good. That's a very good vaccine. That's much better than actually any of our influenza vaccines that are out there. But on a population level, when you have individuals at a high proportion in the population that achieve that efficacy, that's when you can really drive down the ability of COVID to be transmissible in that population. So that's really what we're trying to achieve with vaccination, is both on an individual level, but moreover on the population-wide level, so that we can open up and be normal again.
Okay, so much of the discussion has to do with the timeline of vaccine distribution. Who's first and when can they expect it? Let me bring in Lindsay Cassidy, who may have just dropped the, oh no, she's there. Lindsay, are you with us?
I am here.
Oh, go ahead and ask your question.
Sure. I just wanted to know for those employees that don't have patient contact more in the administrative areas, when we might expect to receive the vaccine. I know obviously supply is limited, and of course, patient care is first on the list. I had heard late spring. Does anyone know a more specific estimate than that, or is it too soon?
Yeah, that's a very good question. So I can give you my projections and estimates, which of course may be completely erroneous. So we have limited vaccine available right now. The help is coming along the way, because if the Moderna vaccine gets EUA approval, we'll have 2 vaccines instead of just 1 with limited supplies. But again, these initial doses will go out to healthcare workers. We're also simultaneously prioritizing residents of long-term care facilities. Again, we've seen outbreaks there. Then as we go through the healthcare and long-term care facility, we'll then move to the so-called essential worker population, which are again, the people who are not able to telework, who as part of their occupation must be out there and interacting with others. And so as a virtue of their occupation are at high risk of getting infection. Also, our first responders are certainly part of that population. We will also be rolling it out to people with comorbid conditions and older adults. Again, these are the people who have high risk for COVID infection. Now, I don't know what your situation is, but if I'm going to assume, let's just say for the sake of this discussion, that you're not of any of those categories and that you truly can telework at home and be safe, then you'll be in that next category where we'll when we have those vaccines widely available and we've finished our efforts of directing vaccination against those prioritized populations, then yes, you would be then next in line. And that would be probably, as you say, sometime in the spring. I'm hoping that in the next 4 months or so, as we go through the dead of winter and into the early spring, that we'll have more and more vaccine available and we'll be successful getting through those prioritized populations, such that by spring and summer, we're continuing to push the effort out to the general population. That general population is, of course, the healthy adult population that isn't part of those other prioritized populations. And then we'll also hopefully have data then for young children, and start being able to immunize children, such that, my projection is that by fall and certainly by winter, that we'll have had the ability to immunize most of the population, achieve that 70% community-wide immunity that I've been talking about, be able to open up society, being able to, again, have the educational sector, K through 12, go back to normal so that our kids can go back to face-to-face education, which is so important. So I'm hoping that will be sometime so that we can have that for the autumn, for the coming fall semester for all of our kids, and also for education at the college and university and upper education, so that our campus also can be fully open for in-person classes as well. So that's my aspiration. I hope I'm right. We may have a few hitches along the road, but again, your question about yourself, I think that it's safe to say, yes, it's probably going to be spring or maybe early summer.
All right, I'm so glad we have this next question, because we've all seen the polls and heard about the data. The number of Americans who are concerned about getting the virus are questioning whether they ought to get it. And I'm going to bring in Charmaine Rochester Ayagokan. I hope I got your name right, Charmaine. I really do. Are you there?
Yes, I am here. Thank you so much, and thank you for this forum. So my question has to do, and I speak to a lot of patients on a daily basis, and none of them are excited about the vaccine. Most of them are diabetes patients and patients with chronic comorbidities. And I always ask the question, what's the real concern? And most of them said this Operation Warp Speed. They think things move a little bit too fast. And is there enough time for safety in terms of the vaccine? So I want you to address that, and how do we help them, especially patients of diverse in the diverse community? They're even more concerned. So what is in place to help educate the community about these vaccines?
That is such a good question, and actually, I'm so glad that you asked it. So I think what it really means is that we have to continue to have these frank and open discussions that not just myself, but community leaders that are, again, the trusted individuals within the population. So these would be religious leaders in communities of color. They could be at the barber shops or whatever. Again, individuals that people trust in the community, next door neighbors that are being able to speak the truth about these vaccines. We have to also be transparent about any of the safety concerns that people have. Again, Operation Warp Speed. I personally don't think that it's a great choice for a name because it almost implies that we're trying to go so fast that we're skipping over procedures for evaluating the safety and efficacy of these vaccines, which is not true. We're not sacrificing any of that. But I think, again, that name evokes perhaps that image in some people. In fact, my personal, I wish we had named it Operation Save Humanity or something which again, communicates this aspirational goal that we really want to save lives as fast as possible. But again, I think we need to continue to be knowledgeable about the safety and the efficacy of these vaccines and to be able to communicate them to our neighbors. And that the only way is to continue to have these discussions like you're doing. And I think hopefully you feel equipped now that you can go back to those patients of yours and talk to them and say, hey, you're high risk of getting COVID. These vaccines have been shown to be safe and efficacious. Let's talk about this because I want you to get vaccinated. This will benefit you. And so once you have these discussions, I think hopefully you are a trusted member that they will listen to, and maybe you can help them to get to that decision point.
Dr. Majette or Dr. Cloran, would you add anything to that?
Yes, I would. I was thinking as you're talking, Wilbur, that what might be really helpful, and maybe there is something like this out there, or maybe ACIP is planning to put one together, like a checklist that illustrates, what are the steps in assuring safety in clinical trials for vaccines, and showing that the trials for these vaccines met all of those milestones. So I think having a visual communication tool that also educates people about the actual steps that they're worried about having been skipped, I think would be really helpful.
Dr. Majette?
Yes, I want to add to that. I definitely understand the concerns about vaccine safety. And even the larger concerns, particularly in the African American community, where folks have some distrust of the medical community, particularly because of Tuskegee, Henrietta Lacks. Those are probably the two big ones that people can kind of recall or think about. So it's a real concern. It's a real I'm not sure if I'd call it a fear, but just a real concern that we definitely everyone that I talk to has that same concern. I would say this: when I break it down, at least in my mind, I think of it this way. If you get COVID-19, you probably have a chance of dying of about, I think in the United States, I think it looks around 1.82% mortality rate. If you get the vaccine, it's minimal. And Wilbur, you can help me with this. I don't think have there been any deaths related to the vaccine? There've been some concerns, but I don't think there's been any deaths.
Mario, you're right. The vaccine has actually prevented serious COVID. So I think that, again, we can show that it prevents symptomatic disease, but also serious COVID, which includes prevention of death and hospitalization.
So if I just look at it that way, if I'm taking my chances and looking at the stats, I'm much better off getting the vaccine and dealing with some potential side effects than I am with dealing with a 2% chance of dying if I get COVID. So that's the way I look at it. That's the way I kind of tell my patients to break it down. It's just a matter of looking at risk and benefit. And I think the risk of COVID is much higher than risk of taking the vaccine.
This is such an important area. I want to bring Lindsay Jones in here, who's written a number of really important comments. I'd rather have her talk about them. Lindsay, are you there?
Sure. Can you hear me?
Yes, go ahead.
Okay. I just want to thank the previous caller for bringing up this important question. I too interact with a lot of communities of color and, hearing their concerns about the vaccine. And so, I appreciate the different strategies in trying to, some people might be okay with seeing a list of different steps so that they're not worried about Operation Warp Speed going too fast. But here's another idea. One thing I was thinking about is there's something called the diffusion of innovation model in public health, and we recognize there are going to be early adopters all the way to laggers. And so how do you encourage these communities who are so reluctant to even try the vaccine? So one strategy I was thinking about is what I'm hearing from communities is they really want to see the leaders on the front lines, not necessarily those that are in the hospital, but who are the people that they're seeing each day in the media that they can, just like Dr. Jarrell said, I took the vaccine. You can rest assured, Dr. Jarrell, there's a lot of people that's watching you and they're using you, interestingly, whether you know it or not, as their litmus test. Now, the last thing I will say is, and really, Dr. Chin, I totally admire what you said about making sure that your colleagues who are on the front lines with patients get the vaccine. But I will say that maybe potentially one unintended consequence is the communities, again, who are looking at their leaders, for you to say that, that kind of, for some, not all, builds into the skepticism. Because a couple things that I've been hearing is they're listening to the news and they're hearing things like places like Johns Hopkins and University of Maryland, their workers are not being forced to take the vaccine. And so they're wondering, okay, well, if they're not being forced, then I'm not going to take it. But I guess what I'm trying to say, and I'm really not trying to stir up any controversy, but I understand that we really need to work together. And so because I'm hearing this, because the prior caller mentioned, these are people that really are concerned, one suggestion would be for those in the front line of media, whether they're university, whether they're government, for them to say, I've taken that, you have no idea how much impact that has, because we see you, we know that there's somebody visible that we can watch. And so thank you so much, Dr. Jarrell, for being on the front lines to do that. And I'll stop here.
I didn't know that people were watching me, Landetta, to see whether I was dead or alive. But I would say that, remember, Freeman Hrabowski, the president of UMBC, has been in the clinical trial. We're hearing that the vice president and the president-elect are going to be taking the vaccine maybe tomorrow. But your point is exactly correct. And so I'm waiting for Lester Holt to announce that. I watch him every night. So you're correct. We need more leaders to step forward.
Well, can I just mention, one of our viewers is pointing out that Presidents Obama, Bush, and Clinton are all getting the vaccine, according to CNN. So that's a great step. I'm sorry, Dr. Majette.
I just wanted to add to that. I'm getting my vaccine this morning, right after this call. I'm headed to get my vaccine, and I see Wilber's thumb up. And so obviously I can speak, at least the community that I'm a part of, African American community. We make up, again, across the United States, about 13% of the population, but we are about 20% of the deaths. The vaccine is going to be a lifeline for us, for those in the African American community, and particularly African American men. There's a lot of things that we're dealing with outside of COVID. We don't need another another insult to take us out. And so I really want to press that, and that's part of what I hope to do once I get the vaccine. We're going to record it. We're going to use that to hopefully do some to let other folks know and do some talks through the family medicine department and across to let folks know that, hey, the vaccine is good. It's safe. It is recommended. It's vaccines work. They can save lives. So I'm gonna stop there.
Alex, we've got time for about what do you think? 8 more minutes. So we're going to keep moving.
Well, it's actually 13 by my clock. Maybe our clocks are set differently. I have 9:47 here, but let's keep moving. A lot of people are interested, are anxious to get that vaccine. I want to bring in Nicole Nash. Nicole, go ahead, ask your question. You're unmuted, Nicole.
Hi.
You can. Yep. Go ahead.
Hi. I was wondering, is UMB going to offer vaccines to all employees, like they offer the flu shot, or will it just be like patient-facing? I mean, eventually, whenever it's time for people to get vaccines.
We're asking that question. Our answer, I think, wants to be yes. But again, we have to have accessibility through the state to be able to say that for sure. We will certainly stand up the mechanisms to give the vaccination, et cetera. There do have to be informatics mechanisms in place to know when somebody's gotten their first vaccination that they're due for the second one. It doesn't get skipped, all those things. But yes, we want to offer that and we want to be part of that.
Great, thank you.
All right, now I wasn't able to give John Jensen a heads up, so this is his heads up that we're going to come to him, but he has a question about testing. John, are you there?
I am. Good morning.
Go ahead.
Mine is unrelated to the vaccine, but while we're waiting for the vaccine, we continue to do testing, and testing is such an important part of controlling the spread of COVID. The FDA just approved a home test kit. And I was wondering if students, faculty, and staff would be able to use that test kit as part of the testing protocol at UMB, or if we have to keep the PCR test with lab results that we can upload to the SAFE system, if that'll still be the standard.
Yeah, I can take this one. Yeah, John, thanks for that question. We are actually just still looking at the antigen testing and making sure that we want to reassure ourselves and reassure the folks that are taking the test that we are that the data is valid and the tests are valid to give us the answer that we want. The worst thing we want to do is give someone a test and tell them that they're negative when they truly are positive. So we're going to do some of our own in-house validation of some of the point of care testing over the next couple of weeks to determine if that's something that we will provide or at least accept as a use on campus here. We're trying to keep our level a little higher than maybe some of the general public because we are a very heavily medical campus. And so we want to make sure that if we do a test, we actually can trust the answer that's given by there. So for right now, we're still only accepting the PCR test for return to campus, but that might change as we get more studies and more information in the next coming weeks.
Alex?
All right, so we have people who are also interested in information about the Moderna vaccine, which, we expect will get EUA, in the next couple of days, God willing. Kim Aumann, are you there to ask your question? Kim? Well, Kim writes, I heard in the news today that the Moderna vaccine is approved for those older than 18, but what happens to those who are younger than 18? I have a 14-year-old and an 83-year-old mother, and I want to protect both of them.
I'll take that question. So I don't think the Moderna vaccine has been officially approved, but it's being reviewed right now. In fact, as we're talking, the FDA's VRBPAC, which is the expert committee, is doing their deliberations, and that will culminate in a vote, which will happen sometime in the late afternoon. Once that official vote goes in, then that recommendation will go to the FDA commissioner, and the FDA commissioner will review that, probably completely agree with the vote, which is, I think, going to be very, very favorable because I've seen the data as well. And so some of my scientific colleagues are on that committee and have seen that data, and I think that we're all similarly pleased with it. So again, I fully trust that the EUA approval will go according to plan. That's why I'm projecting that it'll be by this weekend. So the answer for your question, pediatric studies have not been formally done. For the Pfizer study, the study was actually done in 16 and older. The Moderna vaccine was only done in 18 years of age and older. So for the approval, it will only be for 18 and over. But this past week, Moderna just started the adolescent trials, which is 12 and older, 12 to 18, I should say, or 17. And so that information will be collected in the next weeks and months. I think that very quickly we will have an expansion on the label, kind of legally, to be able to allow vaccination down to at least 12. I think the pediatric trials for the even younger children are also being arranged right now, are in the final stages of being done, so that or being launched, I should say, so that we will also have that information as well. So the answer is it's coming soon. Right now, the pediatric population in general, adolescents as well, are less of the priority because we've seen less severity. That doesn't mean no severity, because we've seen a lot of devastating cases, but they are much rarer. So it is coming. So the first tranche is for your older adult parent. We will be working on the pediatric population.
Wilbur, is CVD going to be doing the pediatric Moderna trials, and what would people do if you are, in terms of getting considered for that?
So I think it's still being arranged right now, but yes, the CVD intends to be involved with these pediatric trials. Jim Campbell is probably going to be leading that effort. He's the chief of the pediatric studies at the Center for Vaccine Development. So I think you can stay tuned for that. Nothing has been finalized yet. And of course, it would have to go through UMB, IRB approval and other levels of approval before we were to have this officially launched. But yes, these are some of the movements that are happening in the background.
Thank you. Alex?
Well, we talked about concerns that people have about the speed with which this is all developed, but some people have expressed concern about what's in the vaccine. So an anonymous viewer wants to know, are there cells from aborted fetuses or used in the production of these vaccines?
So for the mRNA-based vaccines, there are no cell lines. So that question of aborted fetus cells is now for the live virus vaccines. They are grown in cell culture, but they're grown in vero cells, which is it's originated from monkey kidney cells. So that also is not aborted. But there are, again, to be completely transparent, development of those vaccines in stages were done in some of the other types of cell lines that are available. These are cell lines, again, not the cells, were derived, from the 60s from an aborted fetus. So again, that is the long history of some of these other cell lines that are used in research. Again, there are some vaccines that are licensed and approved that are based on these older cell lines. And the Catholic Church has actually reviewed the information and has officially come forward with saying, even though the Catholic Church is very much pro-life and against aborted fetuses, that the scientific benefit, the health benefits significantly outweigh it, such that the Pope really does recommend that people get vaccinated with such vaccines. So again, I think that this is an issue that people do raise commonly. And again, as part of me trying to be transparent with information that I have, I try to communicate this as well. So again, mRNA-based vaccines do not have this issue at all, so it does not need to be a question. Live virus vaccines may, be questioned only in the initial development of those vaccines, but not in the final manufacture of them. So there's no aborted fetus pieces.
Alex, 3 minutes left.
All right, I'm going to bring in Pam Crow very quickly, but she may have dropped out. Oh, well, I'm not going to bring in Pam Crow very quickly. We have an anonymous question about the efficacy rate. Is there something specific that makes the recipient not immune or the vaccine not work? For instance, she writes, I've received the MMR and still don't show immunity. Is that something that's unique to a specific vaccine, or is it genetically unique? In other words, are there a lot of people out there who just won't, their immune systems won't be jump-started by this vaccine?
Yeah, that's a great scientific question that we've been trying to grapple with, trying to predict or understand why some people just are non-responders. MMR is one of the examples where, again, it's 1 in 40 people on the order of that will not respond after the 2 doses of vaccine. Hepatitis B vaccine also is another very good vaccine, but there are some people who are non-responders after the 3 doses, and they have to undergo another 3 doses. So we don't understand that. People have proposed looking, and some people are showing kind of these very specific genetic variants where, again, there may be quirks with the immune system in which these vaccines are just not processed in the same way and don't give full immunity. But my answer is, I don't know, and I don't have a predictive way of knowing who's going to be a non-responder. 95% efficacy right now with these vaccines means that you have a 19 in 20 chance of responding, which is a 1 in 20 chance of not responding. So again, that speaks to the importance of developing community-wide immunity to be able to ensure that we can safely open up society again and prevent transmission in the community.
So I think we're out of time. First of all, there's never enough time, it seems. And Alex, I'll bet you got a whole list of questions left.
We do, yeah.
We'll have to do this again, maybe in January when even more is known about this. I want to thank Dr. Majette, Dr. Chen, and Dr. Cloran for participating in this. It's always enlightening to hear the latest. And the latest will continue to evolve. So we'll figure out another way to continue this discussion. So with that, I want to thank all of those of you out there in the viewer audience that attended. Thank you for doing this. And to our 3 panelists, thank you immensely for all of your work in this area and also for your good advice and judgment on this webinar. So thank you much and see you all next time.